So there were three options for states. States could build their own exchange. They could defer to the federal government to build it, or they could partner with the feds. Connecticut obviously chose the state exchange side, and so I just wanted to walk through and see what other states have chosen. We started with Massachusetts, your neighbor, which implemented health reform in 2006. So their connector is sort of being updated to become an ACA-compliant exchange as we speak. Another 17 states joined them more recently. And so these are the states that are going to have an exchange running in the fall of this year, leading up into 2014. A handful of states, 7 of them said they couldn't build an exchange, but they're going to partner with the Fed, so they're going to help on a lot of traditionally state-based roles, so like overseeing the insurance side, doing the outreach to consumers. But the Feds are going to do a lot of the back-end operations. And the remaining 26 are completely deferring to the federal government to have what they're calling a federally facilitated exchange operating in their state. But these aren't set in stone. States could change perhaps for the next year, for 2015, if they want to change what they're doing, maybe in 2016. At some point it becomes a little difficult because the money starts drying up. But for now, this is the map you'll see for 2014, barring any other interesting changes. So I wanted to just briefly mention what is an exchange. So we have individuals and families, and we have small businesses. And in most states, small businesses are with up to employees of 50. Some can go up to 100, but in general, it's 50 for most states. And so really what you have is people trying to buy coverage that are not in large businesses. Large businesses like governments and large companies tend to have an easier time buying coverage. They have more purchasing power, more options on the table. For these groups, it's actually quite difficult. And not only is it difficult, it sometimes is impossible. So there aren't even options on the table. The whole point of the exchange is to be a clearinghouse. Some people refer to it as sort of a Travelocity or something like that, and I say, no, stay away from that. What it really is more of like a Costco. If there's an online version of Costco, it gives you purchasing power together. You can shop and buy products. It's the same commercial products you see elsewhere. You just get to use the fact that you're a member of a large group that gives you a little better purchasing. Now, the exchange may not have every plan, and every carrier in your state may not participate, although I know in Connecticut it looks like you may, and you may even get some additional carriers. But the exchange in some states might have some, but not all, and so they're going to offer plans. You go to the exchange, apply for coverage, and if you qualify, you get tax subsidies to help you purchase these qualified health plans. The other thing that the Affordable Care Act does is really helps lower income folks who qualify for your traditional programs like Medicaid get into that program. So the exchange also helps you screen and get put into whatever low income benefit program you have. So we're really trying to create a sort of seamless, no wrong door, single point of entry. All those buzzwords just basically says you go to one place, you put in your info one time, and you get put in the right program. This is really miles above where many states are today and what they're doing. So what are the things, what's going to be offered in the exchange? What the Affordable Care Act does is really help create a new bar of what any insurance sold to individuals and small businesses might be. And then there's some additional ones if you want to be sold to the exchange. So one of them for any insurance sold to individuals and small businesses are what's called your essential health benefits. So these are 10 categories of services that have to be covered. Not all of these have been covered in most policies sold to individuals and small businesses. So you won't always see maternity care. You won't always see mental health, drugs, habilitative services. So one of the things all the states had to do, and Connecticut certainly was one of them, was come up with and pick a benchmark plan. What plan are we going to use that's within our state that's going to sort of give us the details? Because these are just a broad 10,000 foot. You now need to go in and say what's included in emergency care, what's included in drugs, what's included in maternity care, and rehabilitative care, etc. So that now applies to these new coverage levels, which is a great new step for insurance in 2014. In addition, plans have to meet what they're calling actuarial value. So this is complete insurance inside speak. I know we have members of the department here. They've been evaluating this for years, but for the rest of us, we had to learn this on the fly, some of this jargon. It really just says you have, through the course of a year, on average, a certain amount of medical expenses. And some percentage of that's paid by the insurance company, some percentage is paid by you through co-pays, deductibles, etc. Actuarial value is just the percentage that the insurance company pays. That's all it explains. So it kind of says how generous is the product you're buying. And the ACA sets out new tiers for what those valuations have to be. A bronze says that percentage must be 60%. So you're picking up 40% as the consumer, on average, an average consumer will, which means it probably has a high deductible, a lot of co-pays, but it might be cheap per month. So it's probably something that you're younger, you're healthier, you want to buy something that's less expensive, that's one of the ways you can do it. Conversely, if you really want something that has a lower deductible or no deductible, or very low co-pays because you have anticipated health needs, you might have a chronic condition, you might be older, you might want to see the doctor more often, then you can go for a platinum product, but you're probably going to pay more per month. So that's all what these metal tiers are. And so from now on, we really refer to insurance in bronze, silver, gold, or platinum. There is an option for people that are 30 and under to buy catastrophic coverage, which is a little skimpier. Now there's going to be an individual responsibility requirement that you buy coverage, and so these are the ways to try to make some affordable options for folks who might just want to buy the bare minimum. This applies, again, to all plans sold in your state for anyone that's in a small group or individuals. They also apply to your exchange, of course. So one of the things to remember is that while we have a large number of reforms that the Affordable Care Act does, there's a series that actually happened in 2010. So this all are now on the books. They happened a couple years ago, 6 months after the Affordable Care Act was signed into law. Things like the medical loss ratio with an 80-20 rule, which said that 80% of all premium dollars that a carrier collects has to actually go to medical expenses. 20% then goes to overhead and profits. And a number of other things like not having any pre-existing conditions for kids, not having any lifetime limits. Those are some of the things that were early, and now we're actually going to have a series of additional ones in 2014. So your insurance department is gearing up to prepare to review all policies for these issues. So making sure they're guaranteed issue, which means they have to be sold to anyone who wants to buy them. No longer can they choose whether they want to take you or reject you because you're sick, reject you because you're a woman, reject you because you're older, etc. That's a huge benefit of the new law. I just mentioned the health benefits, that they have to include the HB, the AV tiers we just talked about, bronze, gold, and silver. That now applies to anything sold in your small group and individual market. So now we get to the exchange. One of the important things to think of is while your exchange is somewhat parallel to this market that exists, it actually sits inside your small group market and your individual market. It is inside, it's part of it. So anything that applies on the outside has to apply to the exchange. But in addition, the Affordable Care Act has a couple additional standards that apply to these plans. And these are new things like making sure that any product sold in the exchange is an adequate network. So enough doctors, enough hospitals, enough providers. Making sure that certain kinds of providers, called essential community providers, so these tend to be your FQHC health clinics, your public hospitals, and ones that traditionally serve lower income folks who don't have a lot of access to care. A certain amount of those have to be included in these plans. And then a couple other standards as well that exchange plans have to meet. So it's really incumbent upon you, the state, to now define those terms and make sure that when the plans submit to be sold through your exchange, they meet all those. So one of the most important things we've seen around the country is network adequacy, making sure really that just because you have an insurance card doesn't mean you get access to a doctor. We want to make sure it means you get access to a doctor and it means you get access to actually a healthy outcome. So some states are putting in what they're calling time and distance standards. So you have to be able to get to an appointment, to get to a primary care provider within 30 minutes of driving or within 20 miles. So several states are looking at that. A couple are saying there have to be ratios of how many doctors per patient. So 1 PCP per 2,000 patients is what some states are looking at. In addition, if you perhaps don't have a particular kind of doctor or enough doctors in your network, let's say oncologists or rheumatologists, letting you go out of network, even if it's an HMO, and paying that provider the in-network rate, because you have no ability to actually see that doctor in network, even though there's only one or two. These are very important things, again, to make sure people actually get to the doctors. Most of you have insurance, you go online, you try to find a doctor, the provider directories online are not that user-friendly, and they're not really that accurate. You go online and you say one's moved, one doesn't take patients anymore, one's dead. There's a lot of these inaccuracies, and I realize it's hard for the carriers, but that's really their issue to deal with. And so what we say is some states are saying you got to update your directory every 2 weeks. You got to weed out all the ones that are incorrect. We're also arguing for a concept where if you're someone who goes online and looks for a doctor and you make some phone calls and none of them are taking patients, you should be able to click on that doctor's name and it should send a note to the insurance company, this person doesn't take patients, or this person doesn't live here anymore. This doctor, isn't alive anymore, so they no longer need to be on your list. Remove them immediately. And I know I bring up the notion of providers being dead on the directory. It's actually quite common that you'll find that listing. It's actually unfortunate. Mentioned briefly on the consumer reporting on the directory. One thing that a lot of states are evaluating, and I think we recommend, is this concept of secret shopping. So, do a small contract with someone, have them, in DC we did it with a bunch of interns from GW, college students, and they called up the books on our Medicaid plan and see if they can get a doctor. And it was about 20% of doctors were taking patients. So we're paying this company, a certain amount to make sure that they have a network, and only a fraction that was available to our clients in Medicaid. And so we ding them. We actually had a withhold penalty. We were able to take some money back from them. And then there's other things. If you're leaving Medicaid, when you're in active treatment, let's say you're in cancer treatment, let's say you're in the hospital, one of the things you want to make sure is that when let's say your income changes and all of a sudden you change from Medicaid to now you have to buy an exchange because your income went up. Well, if you're in active cancer treatment and that oncologist isn't in your network that you're going into, that's a problem. And these are life or death decisions. Or if you're actively in the hospital getting treatment for some kind of long chronic issue, making sure that the exchange plans have to continue paying that provider at some rate we can all negotiate, at least until that episode of care is completed. And then essential community providers, actually in Connecticut you have a great standard. It's one that we actually cite in other parts of the country. You're requiring up to 90% of FQHCs and 75% I think all of them statewide to be in your plans. We think that's really a great way to make sure that for folks who happen to go to those places, and that's where the uninsured were today, that's where they go. So if you're going to give them coverage, you might as well let them have an option to keep seeing their same doctor. Another thing that many states are debating, including Connecticut, is this concept of standardizing what a health plan in your exchange. So, you have that bronze, silver, gold, and platinum. You have 5 or 6 insurance companies. They're going to sell a number of plans, but they're going to look all different. And one of the things we really sold the Affordable Care Act on is finally getting some way to easily pick what plan you want to buy. So this apples-to-apples comparison thing. We do this very easily whenever we buy televisions and airplane flights and stuff. It's almost impossible with the way the insurance market's set today. So this is the kind of thing you'll get from your booklet from your insurance company, which describes, and I apologize it's very small, but it'll say what your copays are for each type of visit. So ER visit, PCP visit, specialist, mental health specialist, labs. And what we're saying is it might be good to have in each tier, so for every bronze plan, have at least one type of bronze plan that's exactly the same for each carrier. One type of silver plan that's exactly the same, copays, etc. So then you really force them to compete on 2 things, price and network. And I think people in general can understand price and network. They can handle 2 variables. At least they know they can cross. And if the carriers want to offer some other variations of designs, that's something states can consider. And I know here we just met with the exchange this morning, they're certainly diving in that direction. But speaking of which, there is this concept of how many plans should be offered in your exchange. Right now the market is flooded with plans, but not because they're all good, it's because carriers tend to just offer a lot and pick up market share because they have just their name out there. Or the more different plans you have, the more you're able to sort of segment risk into smaller and smaller pools, which helps you sort of price up a little bit. What we know from research is that people really can't handle a certain number of plans. We saw it with Medicare Part D, we see it with Medicare Advantage. And so in general, they say somewhere between sort of 5 to 7 to 10 things on one screen at one time is what any human can really handle. So you may have more than that, but you want to make sure Exchange can filter that down, sort of like the the online tools that you have for Expedia, for Kayak, that lets you figure out what do you want to buy, how much of a deductible do you want, what kind of network do you want? Do you want an HMO or a PPO? But it's still useful to make sure you don't have a flood of products. And I know Connecticut's looking at doing 1 standardized plan and up to 2 other plans that each insurance company can offer at each tier. So each company will offer 3 bronze, 3 silver, 3 gold, 3 platinum. So they'll give you up to 5 or 6 plans. Companies are looking at about 72 plans will be on their exchange. In some states they're not having any limitations. There could be thousands of products. In other states they're going even more restrictive. So lastly, one of the biggest things we want to do is we want to really foster competition through this market. We all talk about this is private commercial coverage, how the private sector can help us achieve price efficiencies that has not really been seen in insurance for the most part for decades. But now, for the first time, through a very simple thing, through the internet, we're helping try to bring that. By lining plans up side by side, this is the Commonwealth Connector in Massachusetts. This is, I put in my demographics for where I lived in Somerville at the time, put in my age, my income. And these are the products I could buy at that silver level if I wanted to. The prices are not that cheap, as you can see. It's still quite pricey. But at least you're able to see between the different products. And then there's other information that this analysis wasn't able to show because I didn't put in all the information. But what is their deductible? What is their copays, etc. This is something we just really don't have in the market today to buy coverage for you or your family, or for you and your small business. This is a huge tool. I mean, brokers and other assisters are going to help people sit through this and walk through this place. But one of the most important things is, even with this, even though we hope competition just by having prices next to each other will help put some downward pressure on cost, it's unclear. Insurance is expensive. It's very untransparent. Insurance carriers have more information than sometimes we always have. So really, affordability is something we want to make sure. We have a lot of uninsured. We want to make sure they buy this insurance. So some of the things is making sure that it is in fact affordable. So this graph just shows the Affordable Care Act set sort of upper limits of what you would have to pay if you're eligible for it, if you're under 4 times the poverty limit. So the top line, the black line, associates with the left scale. So that's percentage of your income. So based on where you are on the x-axis is your percentage of poverty. And so I have the incomes down there for whether you're a household of 1 or a household of 4. So if you're a family of 4, let's say at 250% of poverty, you're making $58,000 a year. You and your spouse, 2 kids. And it says the cap goes up to about 8.05%, I think, is what it says. You can pay no more than up to 8.05% for a particular kind of plan, a silver plan. And so that represents, and so the other graphs, the middle graph there, the orange is what that is in real dollar amounts. So as you can see, that's a little under $5 grand. That's a decent amount of money to be paying for a policy for your coverage. And that's in addition to rent and other cost of living issues, especially in a state like Connecticut or in New England where cost of living is high. Affordability becomes a huge issue. And we're setting the standard. This is for across the country. Standard of living in different parts of the country, the South or the Midwest states is very different from New England or from certain urban areas. So we hope that states will take some of this stuff into account as they make some of these decisions. This is just a quick example of how this works. If we had a 45-year-old female who was living alone, so is a family unit of one. Let's say they're at 250% of income. They make a little under $13.50 an hour. So it's not a lot of, this is not a high-wage job by any means. Their income cap is at 8.05%, so about $2,300 is what they have to pay up to during the year for their insurance coverage. So if the average exchange premium for that silver plan in their state is, let's say, $5,700, that's actually probably a little cheaper than what it would be here in Connecticut. It would be a little higher cost than where this data comes from. That means the tax credit's basically the difference. They have to pay $2,300, but the cost of the coverage is $5,700, so they got $3,400 in tax credits coming from them from the feds. But that's only if they buy a silver product. So that's if they use the default benchmark product. If they want to buy down, they can take that $3,400, or sorry, if they want to buy up, they can take that $3,400 and buy a more expensive product, but they have to pay the difference. So now the cost will go up for them. Or they can buy a cheaper product and they get to save the savings. So that's how the tax credit works. That's one of the ways we can try to make it a little more affordable. But we do think that really how you build your exchange is going to ultimately define what those prices are going to be. So as you see, Connecticut has been a leader in covering, through Medicaid, through other programs for a long time. We're now building this new market, and we're hoping that through collective work, I think you need your insurance companies, your brokers, your consumer advocates, your medical providers, your insurance department, your exchange staff, really at the same table trying to work out and hammer some of this stuff out. We have 6 months to go, a little over 6 months to go before October, when everything has to work. And anyone who's launched large programs knows that rarely does everything work. And so we, at the center, we're certainly looking forward to working with states and helping you, and I think you all have great expertise within the state to make some of this happen.